from the American Academy of Pediatrics.
The recent purge at the CDC's Advisory Committee on Immunization Practices is disrupting vaccine delivery.
Let's look at the vaccine approval process and how it might change.
The part that we're most concerned about is that data could be taken from that system and used in a way that misinforms people who are trying to make the best decisions they can about whether or not to vaccinate their children.
Plus, research shows an alarming trend in adolescents' use of products called nicotine analogues.
Just because something is labeled non-nicotine doesn't mean it's safe. These products contain chemicals that act like nicotine, possibly more addictive.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians, for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a look at changes to ACIP and vaccine infrastructure.
When we last had Dr. Shelley Fiscus on, it was to talk about how she was fired from her job as medical director of the Tennessee Vaccine Preventable Diseases and Immunization Program. We talked a lot on that episode about misinformation.
And that was a long time ago, episode 73, back in August 2021, before the record-breaking measles cases we're seeing in this country now, and before public health measures that we know and trust to keep children healthy were challenged or changed without consideration for expertise or even what's best for kids.
I am sad, David, that we are in a time where people are being asked to sacrifice their health and their children's health for what is just bad information. Parents are already stressed. They want to do what's best for their families, and being told they can't trust experts like pediatricians, honestly, this makes things more stressful for people.
So then, what is the process for recommending vaccines, or at least what should it be? Dr. Shelley Fiscus is back with us today to describe how the vaccine infrastructure has changed and why we have cause for concern about how these life-saving interventions may or may not be distributed moving forward.
Dr. Fiscus is a pediatrician who now works in Maryland as the chief medical officer for the National Nonprofit Association of Immunization Managers. Shelley, welcome back to the show.
Thanks, Joe. It's good to see you and David. Again, I guess I know what it takes to get me invited to the show. I will warn
crisis,
you.
A vaccine crisis.
I am back in Tennessee. I'm actually moving my mom from her house to her new apartment. So I am currently in her closet trying to be quiet. And so if anything sounds irregular with the internet feed, it's my fault. And I'm sorry in advance.
Well, Shelley, we are happy to have you back, even in your mother's closet. And we're sorry it's taking a national crisis to get you back in our company. We've talked in the past about the Advisory Committee on Immunization Practices, or ACIP, on this show. And we know Dr. Bonnie Maldonado, Dr. Sean O'Leary, and Dr. Paul Offit have all been part of that committee in some form. What traditionally has been the role of the ACIP?
So the ACIP is a very important committee that advises or makes recommendations about how vaccines should be used to the CDC, and therefore from the CDC to the rest of us about how we should use those. And I will, in full disclosure, say that as a pediatrician for 20-something years, I never once listened to an ACIP meeting. They go on for usually 2.5 days. It's something like 15, 16 hours of people talking about vaccines. I didn't have the time. Most people don't have the time. I really didn't start listening until I became the medical director of the vaccine program in Tennessee, and then it was my job to do it. So I don't fault anyone who hasn't paid real close attention to these meetings, but we need to all be paying real close attention to these meetings now. Typically, this is a large committee, 15, 17 most recently, experts in immunology, vaccinology, bench research, infectious diseases, pediatrics, adult medicine, across a very wide spectrum of academia and private public folks, and really well respected. I mean, you mentioned Paul Offit and Bonnie Maldonado and Sean O'Leary. I mean, these are really top-notch, well-respected experts in their fields. And that's typically what we expect of the ACIP. I think everyone knows that a couple of months ago, the secretary dismissed the current 17 members of the ACIP, including Bonnie Maldonado, and replaced them with initially eight, now 7 different experts who, frankly, do not have the amount of expertise in immunology, vaccinology, infectious diseases, pediatrics, internal medicine, et cetera, that we would expect of the committee. And one of the big problems really is that right now there are only 7 sitting members. So at this last meeting that happened in June, they only have to have a majority vote, which means 4 people is all it takes to make a decision about how vaccines are recommended in the United States. And that's a very small number of individuals with varying levels of expertise in this area who are making really, really important decisions about how vaccines are used. Typically, the committee will make a vote on certain recommendations that are brought to them by different work groups of the ACIP that are vaccine specific or disease specific. So flu work group, COVID work group, RSV work group. Those recommendations will go to the committee. A huge amount of information will be presented to them during a committee meeting, and then there will be a vote on whether or not the specific recommendation will be made. And once the committee decides, then those recommendations go to the CDC for the CDC director to sign off on. When that happens, they get printed in the Morbidity and Mortality Weekly Report, the MMWR from CDC. And once that happens, then it's official recommendation from the CDC, and that's what we go by. We start vaccinating people. In the absence of a CDC director, as we are now, those recommendations are actually going up to the Secretary of Health, to Robert F. Kennedy Jr. at HHS. So until we get a CDC director, any of the recommendations that are coming out of ACIP are going to the Secretary for his sign-off.
Well, whom can pediatricians and the public turn to for a vaccine schedule that is strongly supported by science?
Well, AAP has always had their own published immunization schedules, and they have very clearly said that they're going to continue to put those schedules out, which is huge. Even if the CDC schedules come down off the website or are changed, there are lots of archived copies of those. Immunize.org has archives of immunization schedules. So they're a great reference for immunization-related materials and information, especially for pediatricians and other healthcare providers. So I would definitely check them out, as well as AAP. But this is a time where everyone in the House of Medicine, from internists to obstetricians and pediatricians and family medicine doctors, are all pretty much outraged by what's happening, and where that group of hundreds of thousands of physicians is really, speaking out and pushing back on some of the departures from what typically happens in the process of the ACIP.
So, Shelley, I think there's also some concern regarding federal funding of vaccines, specifically the Vaccines for Children, or VFC program. What do they cover, and where do those funds come from?
The Vaccines for Children program is a federal entitlement program, and that means that we don't have to go fight for funding every year to get vaccines covered for the program. It would take an act of Congress to actually undo the funding for the VFC program, and that's good. That keeps this very secure and hopefully apolitical. So every state or jurisdiction that has an immunization program has a budget for vaccines that are purchased through the VFC program. And those vaccines are purchased on a contract that CDC has with the manufacturer that's at a discounted price. And then those states or jurisdictions allocate or receive the orders from the VFC providers in their jurisdiction to give those to their patients. Those vaccines cover children who are eligible for Medicaid, who are under or uninsured, or who are Alaska Native or American Indian. And that amounts amounts to about 50% of the children in the United States. So the funding for those vaccines should be stable, even in a climate such as the one we find ourselves in, where we have concerns is around the funding to the immunization programs themselves. Because if we don't have adequate funding to your state or jurisdiction's immunization program to be able to administer that program, to put through the orders for those VFC vaccines, to communicate to you about what's going on in the world of vaccines, to run your immunization information system or your vaccine registry, then we can really do some shakeup to the ability to just administer the program, which then could be disruptive to getting vaccines to those kids who need them.
Are there concerning state-level disruptions, since you mentioned there are differences in funding for vaccines through states, that pediatricians should be aware of?
So in some states, there are some state-level decisions that some pediatricians might feel. One of those is universal hepatitis B birth dose. So in a handful of states, I know North Carolina, David, I think North Dakota, Pennsylvania, and a few others, they actually used some of their federal funding to purchase all hepatitis B vaccines for all babies, regardless of their insurance status. And that means that those hospitals don't have to stock two separate supplies of hepatitis B vaccine, one for their VFC babies and one for their commercially insured babies. They can just have one pile of vaccines. Last year, CDC changed a rule, and this was actually prior to this administration or any of the more recent disruptions we've seen. But they changed the rule and said that you cannot use federal 317 funding to purchase hepatitis B birth dose vaccine for babies anymore. And so in those states where federal funds had been used to cover vaccine for everyone, including those children with commercial insurance, that as of July 1st of this year is no longer the case. And so now those birthing hospitals will have to either fund those doses for their commercially insured babies themselves, or they're going to need to purchase doses that are billed to commercial insurance and have those completely separate from the doses that are provided through the VFC program for those children who qualify.
And we can't have a conversation about vaccines without talking about how much they're monitored for safety, particularly when they're released. Can you tell us more about the Vaccine Adverse Event Reporting System, or VAERS?
Sure. This gets talked about a lot, especially on the opposition side to vaccines. And it's really important that people understand what VAERS is and what VAERS is not. So many of you know that if you have a significant adverse event from a vaccine that you've given to a patient, that you need to report that to the online Vaccine Adverse Events Reporting System, or VAERS. And there's a form online that you fill out that talks about the circumstances around the vaccine that was administered, what the adverse event was, and some other information. And then if CDC looks at that when they analyze these data and say, you know what, we've seen a whole bunch of other cases where this particular thing has happened in this kind of a circumstance, then they can actually contact those individuals or contact the reporting provider and get more information. And, perfect example of this working was back when RotaShield vaccine was withdrawn from the market in the late 1990s because it had caused, I think, 14 cases of intussusception amongst babies who'd received that vaccine. 14 cases. I mean, it's out of hundreds of thousands of doses of vaccines, there were 14 of these cases that were picked up through VAERS, and that led to the withdrawal of that vaccine from the marketplace. And it took us something like 10 more years to get another rotavirus vaccine because of that. The thing about it is it's called a passive system. So that means that people have to actually go and intentionally report to this system. No one's going to reach out to them and say, oh, we heard you had this or that thing happen from getting a vaccine. And things can be reported to the system that may or may not have been caused by a vaccine. And so you cannot determine causation from looking at VAERS data. And you'll see all the time in kind of opposition information that's put out that, VAERS, there were 14,000 cases of death reported from COVID vaccines. No, that is absolutely incorrect to say that there were 14,000 cases of deaths from COVID vaccine, because you can't determine causality with that database. Maybe all of those people were 95 years old and their death had nothing to do with a COVID vaccine. Or maybe some of those people, as we actually find when we dig in, died by firearm or died in a car crash or died from leukemia that was diagnosed prior to their receiving a vaccine. All of these things get reported, but it takes going through that data and understanding exactly what it is that you're seeing there to try to determine whether or not there is an association between what is reported and whether it's just by chance that this thing happened after someone receives a vaccine.
So, Shelley, do you think we can expect changes to the VAERS system, and how can we ensure that the reports that are being filed there are as accurate, at least as they have been in the past?
Well, I don't think we can ensure much at this point. There have been signals from the Secretary's office that there will be changes to the vaccine injury compensation program. There will be a different kind of analysis going on with the vaccine safety data link, which is a huge pool of active surveillance of multiple very large medical systems to actively look for an association between vaccines and certain adverse events. We don't really know what might happen to the way VAERS is managed. Right now, it's co-managed between FDA and CDC. It could be that VAERS has moved outside of CDC. There's been some talk about that. The part that we're most concerned about is that data could be taken from that system and used in a way that misinforms people who are trying to make the best decisions they can about whether or not to vaccinate their children.
Are there other parts of vaccine management in this country that you are worried about quickly changing and possibly affecting access to vaccines here in the United States? Because we know the majority of families want to get their children vaccinated.
And that's a super important point, Joe, that the majority of people do want to get vaccinated and do want to have their children vaccinated. And I think we often lose sight of that when we're hearing about increasing vaccine hesitancy or lack of confidence. We start to feel that this is a battle that we're going to have to fight with every patient all the time. And that's just not the case. The majority of people that come in to see us want to vaccinate their children. They may have questions, more questions than maybe they would have had a few years ago. And we need to take the time to answer those. But they still want to vaccinate their children. But there are lots of different ways that the whole vaccine ecosystem is kind of under threat right now. So if, for example, there's a change to the way the vaccine injury compensation program works, where that program goes away or that program changes the way in which it operates, then that could be a real threat to having manufacturers who are willing to make vaccines in the United States. If we don't have proper funding to immunization programs to be able to pay for your state or your jurisdiction's IIS system, your vaccine registry, or if they don't have the staff or the bandwidth to be able to adequately administer programs like the Vaccines for Children program, then that is a threat to being able to get vaccines to people. If there are changes on the local level about whether or not certain vaccines are going to be allowed to be administered through your local health department, and that's maybe the only place that a child in a particular area can reliably get vaccines, that would impact the ability of that child to get vaccinated. There's fragility at every level of this system, from manufacturing to how we get a vaccine in the arm or the leg of someone who needs it, that are at risk. And if any one of those spokes in that wheel breaks, we can really have a significant problem trying to get people vaccinated. And of course, as always happens, the people who will be most impacted by that are going to be children who are living in poverty or who live in rural areas where access to good pediatric medical care is already difficult for them.
Shelley, before we let you go, we know that over 90% of American families want their children to get fully vaccinated. Do you have any last takeaways for pediatricians worried about those families having access to those vaccines?
Well, I think there's a lot that we as pediatricians can do to help with that. And, while I completely understand pediatricians, really wanting to make sure that every patient that they see is fully vaccinated according to the CDC's recommended schedule as we know it, there are going to be a lot more questions now coming from families. And we really are the most trusted person. And we still see that in the surveys of parents, that the people they trust the most are their pediatricians and your nurses that work with you. And I think we're going to need to have a lot more grace and a lot more patience in working with these families and understand that we may not get them to vaccinate at the very first time that we offer vaccines to them. And we may have to be a little more patient and understand that a partially vaccinated 2-year-old is better than a completely unvaccinated 2-year-old, and really work with these families and try to bring them in. I mean, I was a pediatrician who, we would really only vaccinate at well visits. And this is a time where we really need to be looking at every opportunity when a child is in the office to look at their vaccine record and make sure that they've received everything they need to receive. And if this is a visit where they could potentially receive another vaccine that's due, we really need to take advantage of that or have those conversations. And I think we need to be really savvy about pre-bunking. So if you're not familiar with that term, that's when we say, you're going to hear from someone at some point that vaccines cause autism. And here's why that is an incorrect statement. And so, you kind of get out ahead of some of the information that might be coming down the pike so that they're already prepped, that this statement doesn't take them by surprise. They say, Dr. Hill actually told me that someone was going to say this and told me that this is wrong for these reasons. I think it's important that we do that. And I think it's important that we start talking about vaccines from the very first moment that a parent brings their child into us. So if that is a 2 or 3 day check, that is a perfect time to say, here are the vaccine information statements for the vaccines that I'm going to recommend that you give to your baby when we see them at 2 months of age. And I would like you to look these over, to come with your list of questions. You can email me. Here are some good resources from AAP or Children's Hospital of Philadelphia or other places that you trust where you can get information. And if you have any questions about things that you hear, please come and talk to me about it and give them time to go back home and have conversations with their partner, with their grandparents, with the neighbors, and come to you and open that dialogue very early on, so that we're not coming at them at the 2-month visit with a stack of papers and saying, these are the vaccines that your child's getting today. Any questions? And them feeling like they're sort of backed into a corner.
Well, Dr. Shelley Fiscus, this conversation makes me feel a little bit better about understanding vaccines and making sure we help our patients do that too. So thank you so much for joining us today.
Well, thanks as always for having me back, and I hope to be back again, and maybe not with a national vaccine crisis.
We would love that. And if you want to learn more about vaccination in the United States, visit us at aap.org/podcast.
Coming up, we'll discuss adolescents' use of new vaping products called Nicotine Analogues.
David, you mentioned on a previous podcast that one of your adult children has been trying to quit nicotine. How is that going for them?
Yeah, I'd say he's in a harm reduction phase right now. He's trying to at least not smoke cigarettes, but the degree to which even that reduces harm isn't at all clear. It turns out he started vaping when he was quite young, and that is sadly typical for young people in his situation.
I'd say my kids are safe for now as they're all under age 7, but stories like yours worry me, and it seems like the market for nicotine products is changing really fast.
So fast, in fact, that our next guest just published an article in Pediatrics on a thing that I didn't know existed until I read it.
You must be talking about Dr. Louisiana Sanchez and her study, Awareness and Use of Vaping Products with a Nicotine Analog Among Adolescents and Young Adults.
I am. Dr. Sanchez is currently a postdoctoral fellow in tobacco regulatory science at the University of Southern California. Louisiana, welcome.
Thanks for having me. I'm happy to be here.
So, Louisiana, like David, I'd never heard of nicotine analogs until I read your paper, and there were names like Spree Bar in there. Can you explain what these analogs are, and can you discuss which ones are already on the market?
Of course. Nicotine analogues are lab-made chemicals that are designed to act like nicotine in the brain. One example is 6-methylnicotine, which is nearly identical to nicotine, but has a methyl group added to its chemical structure. Now, that small change, that chemical tweak, means it's not legally classified as nicotine, even though it still binds to the same brain receptors. And as far as we know from preclinical studies, it may even bind more strongly, which raises concerns about addictive potential. Now, what makes this trickier is that companies are not calling it 6-methylnicotine or nicotine analog on the label. In Spree Bar, it's branded as Metatine, and in Aroma King, which is another brand using 6-methylnicotine, it's labeled No-Nic. And the way these trade names are presented, often without the word nicotine, can make it seem safer or unrelated to addiction, especially to teens who may not look beyond the branding. Now, on top of that, these products are often promoted on social media with messaging like same nicotine buzz, but without the nicotine, clean buzz, or innovative pod system, even revolutionary products. So it's easy for teens to get the impression that they're harmless or not part of the nicotine conversation at all.
And what do we know about the health effects of these products?
Right now, we know very little about the health effects. There are no human studies, and most of what we have comes from preclinical animal research. Those studies suggest that 6-methylnicotine may be more addictive than nicotine. What I mean is that it could have a stronger effect in the brain at the same dose. And also, we really don't know what the long-term impact might be on the adolescent brain. So these products are being sold and used before we even understand the health consequences.
But pediatricians know that tobacco products are highly regulated in the United States with warnings and minimum ages to purchase them. Is the same true for these nicotine analogs?
That's the core issue. They're not regulated under current federal tobacco laws. Because 6-methylnicotine is not technically nicotine, it does not fall under the U.S. Food and Drug Administration, the FDA's definition of a tobacco or nicotine product. And that means it's not subject to the pre-market tobacco product application process, or the PMTA. Normally, the PMTA is what the FDA uses to review new tobacco and nicotine products before they're sold, looking at safety, addictiveness, and how likely they are to appeal to youth. But these nicotine analog products are bypassing the process entirely. That means no safety testing, no age or flavor restrictions, no warning labels, and no evaluation of how these products affect the population. So right now, a product that acts like nicotine and may even be more addictive can be sold without going through any of the usual public health checks.
And what role do these chemicals play in the vaping industry overall?
Well, first of all, they're not just showing up in vapes anymore. Of course, one of the best known examples is the Spree Bar, which is a flavored disposable vape. It usually contains 12 milliliters of liquid with about 5% 6-methylnicotine, which is similar to what you find in a high-strength nicotine vapes. But now we're also seeing 6-methylnicotine in pouches, which are small, spit-free packets placed between the gum and lip, kind of like chewing tobacco, but more discreet, which is one of the reasons they're so popular among youth. So Aroma King makes a product called No-Nic pouches that's packaged and dosed similar to popular nicotine pouches like Zyn, including similar strength options, but usually found in even higher milligrams, like 20, 25, or even higher milligrams of 6-methyl-nicotine. So nicotine analogs, babes and pouches, are available in a range of doses and flavors, making them more appealing and customizable to youth. So while the packaging and delivery look familiar, what's inside is a chemically distinct substance that's not been regulated. And the fact is that we're likely to see more brands entering the market with 6-methyl-nicotine or even similar compounds, especially as companies look for ways to bypass nicotine regulations while still delivering a buzz. That's why it's so important to catch this early before the market expands more.
And so that's what you tried to do with your study. You wanted to gauge if adolescents or young adults were aware of nicotine analogs. How did you get data for this?
So we asked participants a straightforward set of questions. First, we gave them a brief description of what nicotine analog products are, including brand examples like Spree Bar and the trade name Nicotine. For some participants, we even included images of the product packaging to see if that helped with recognition. Interestingly, awareness and use results didn't differ between those who saw images and those who didn't, which gave us more confidence in how we were measuring them. Then we asked whether they had ever heard of these products and whether they had ever used them. So we were able to measure both awareness and experimentation use based on how they responded to that short description.
So in this survey, how many of these youths were aware of these products, and then how many were using them?
So we found that about 1 in 5 adolescents and young adults, precisely 20.1%, had heard of nicotine analog products. Now, what's striking is that these data were collected between May and June 2024. While Spree Bar entered the U.S. market in October 2023, that's only about 7 months on the market. Now, one finding that stood out for me was that even among youth who had never used any tobacco or nicotine product, nearly 15% reported awareness of this nicotine analog. So we're not just talking about current nicotine users. These products are showing up on the radar on kids who have not tried nicotine at all. So in just a few months, really more like half a year, we were already seeing pretty widespread awareness, which shows how quickly these products are reaching young people, even before most people have heard of them in the public space. And to your second question about use, our study shows that 8.4% of the adolescents and young adults we surveyed had tried a nicotine analog product. Awareness and use were especially high among youth who already used e-cigarettes, nicotine pouches, or other nicotine products. We also saw that adolescents and young adults who use multiple nicotine products were especially likely to try nicotine analogs. So that suggests that these substances are not replacing nicotine. They're being added on, which could escalate dependence or long-term use. It's also worth noting that this was ever use, meaning they tried the product at least once. We don't know, at least we don't know yet, how frequent or sustained their use is, but the early uptake is enough to raise concern.
And knowing that there's concern and there's so much more that we have to learn about these products, do you have any last takeaways for pediatricians before they go read your study?
Of course, the biggest takeaway is that just because something is labeled non-nicotine doesn't mean it's safe. These products contain chemicals that act like nicotine, possibly more addictive, and they're being sold in flavored, youth-friendly formats with no oversight. Pediatricians are in a powerful position to act early. That means asking open-ended screening questions like, have you tried anything that says it's not nicotine but it gives a buzz? Also, helping families understand that these products are unregulated and potentially harmful, even if they don't carry the nicotine label. And of course, supporting local and federal efforts to close the loophole that's allowing these products to reach teens so easily. Now, the good news is that we're talking about this now, while the products are still relatively new. That gives us a window of opportunity to educate, intervene, and hopefully prevent this from becoming the next major wave in youth addiction.
Well, Dr. Louisiana Sanchez, thank you so much for talking with us today.
It was a pleasure. Thank you so much.
To read the article, Awareness and Use of Vaping Products with a Nicotine Analog Among Adolescents and Young Adults, go to aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Joanna, we might have mentioned that 2 of our 3 sons are both doing internships in D.C. this summer, but not together, not even living together. But I got a chance to be invited to speak in D.C. this last weekend. So not only did I get to speak, but I got to see both of them, taking them out to lunch, take them out to dinner, just connect in the middle of the summer. And I got to tell you, the more they do, the harder this gets. So that was just really treasured time for me.
Oh, that's so fun. My Say Ah is also about my kids. I just am really excited. I really love 18 months to 2 years, and that's the time period that my youngest is in right now because she's not full toddler tantrum yet, but she is gaining a bunch of really cool toddler skill. And the cutest thing that she does is she has this like really exaggerated way that she nods her head when she wants something, and it's like comically funny, but it also is like, oh wow, she's like really responding now in really cool ways, and her language is just like really taking off, so it's really, really fun to watch.
Dude, development is the coolest. I think that's why we love doing what we do, or at least part of it. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss counseling teens on contraception.
We'll talk to the author of a new policy statement, Dr. Mary Ott. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.